Good evening, everyone. Thank you so much for joining us at our monthly MOASC lung cancer webinar. And my name is Ashkan Lashkari, president of MOASC, and I wanted to introduce to you our discussion today. We'll be focusing on the use of immunotherapy in metastatic non-small cell lung cancer. Certainly a broad topic, but our moderator, Dr. Husain, will be able to kind of put this in good detail for us to be able to kind of take home some keynote points and some updates from the recent meetings that we've had. We're very fortunate to have a couple of discussants with us who are actually not from the California area. We have Dr. Patrick Forde. Am I saying your name right? Forde or Forde?
Forde, but either is fine.
Forde. Okay. The E is silent. Dr. Patrick Forde, who's the co-director of upper aerodigestive malignancies and associate professor of oncology at the Johns Hopkins Medical Center in Baltimore. And we have Dr. Jared Weiss with us, another specialist in lung cancer, associate professor of medicine at UNC or University of North Carolina. Thank you both for joining us. Dr. Husain, I'm going to kindly move it over to you, and we're all eager to hear you guys. Thank you.
Thank you so much, Dr. Lashkari, and it really is a true honor and pleasure to be able to have this discussion with colleagues and friends, partly because what we're going to be speaking about today is a core element of lung cancer and really kind of dissecting some of the nuances as it pertains to immune therapy considerations in non-small cell lung cancer. And so while this is a big topic, we're going to focus on some areas, and I think this is a pretty open and a good stage to have some friendly discussion, even around controversial topics, partly because in lung cancer, as we know, there are areas of gray in terms of our interpretation of the data and also kind of understanding the data and really hearing from different thought leaders about practice pattern considerations, I think is really a goal here. So again, there's not necessarily any, say, categorical right answer in some of these discussions, and it's more about just really understanding experience, practice pattern considerations. Also, there is an interest to try to really understand kind of where the field is moving, some of the clinical trial considerations and ways to think that through. So with that color and lens, we're going to approach the discussion today. So with that being said, actually, we're going to start with a case. And this is a case of one of my patients who's a 74-year-old female who had a new diagnosis of lung adenocarcinoma with a 3-centimeter right lower lobe lesion, also liver lesions, a brain MRI, which showed a 1-centimeter lesion in the parietal lobe of the brain. Her PD-L1 was 0, and molecular profiling showed a KRAS mutation, G12V, and an STK11 mutation. So as we've discussed on some of the earlier discussions on this, KRAS is a big topic. KRAS and really understanding codependencies is a big topic. And in this specific case, next generation sequencing was done to find those alterations. So before we get some initial thoughts from our discussants on this case, wanted to kind of just bring to light some of the typical framework that we think about, and this was adapted from a slide from Justin Gaynor at Massachusetts General Hospital, really kind of setting a stage or a framework for thinking about some of the considerations in the upfront initial diagnosis and treatment setting of lung cancer. So here on this slide, we can see for non-squamous histology, cornerstone of therapy is molecular profiling. And generally what's recommended at this point and part of NCCN guidelines is broad molecular profiling, looking for obviously the FDA approved genes and even kind of ones on the horizons to really push the limits, and those include HER2 as well. And then if a molecular aberration is found, targeted therapy indicated, no molecular alteration that would be indicated in the front line. PD-L1 is a core element of deciding between some of the strategies. These are listed over here with, and in this case, multiple agents listed. Again, we're going to go through a deep dive into all of these with specific kind of interest about looking at how we think through monotherapy decisions, also dual checkpoint inhibition, as well as even emerging data. I'd love to hear the discussion about VEGF and the thinkings around VEGF. At ASCO, we got some data in the second line setting with the addition of VEGF and whether or not that's being integrated. Also, some considerations, thinking through PD-L1 score, and particularly actually the 1 to 49s. For these patients, a standard of care is the integration of chemotherapy and checkpoint inhibition. And, could that evolve, and under what circumstances may a practice pattern, really be warranted for monotherapy, or should there be considerations for additional, doublet type of approaches in that scenario? And then, considerations also about the PD-L1 negative patients. We're going to spend some time talking about non-squamous. We're also going to talk about squamous. So maybe with that, actually, let's go back to our case. And I may actually ask Dr. Forde, a little bit about, Dr. Forde, when you see patients who fit this type of scenario, what generally kind of goes through your mind in terms of how you select the front line therapy for patients?
Yeah, I think, Hatim, there's a few things. I think PD-L1 is key, ECOG performance status, and I guess in this case we can assume that the patient has a good performance status and comorbidities. But the other things are kind of softer things in some degree. So the mutation status, obviously it's G12V, KRAS is a non-targetable mutation at the moment, and STK11 is also one that we sometimes look at in terms of responsiveness to immunotherapy. But the other elements here, the brain metastasis and the liver metastasis, are two other concerning characteristics. So overall, this is a picture where I'd be a bit concerned about the prognosis, and that the prognosis may be a bit worse than we would normally expect with, say, for example, chemo, pembro, or other therapies like that.
And Patrick, I may just ask you actually, this point at one of the ISLC targeted therapy meetings, there was data presented about Ipi-Nivo, so CTLA-4 PD-1, in patients with STK11 mutations. Are you familiar with that data? And also, kind of, what do you think about that approach? And are there certain subgroups where one would consider CTLA-4 PD-1? And how do you think through that decision?
Yeah, this kind of a characteristic is the sort of patient I would think about for that, either the checkmate 9LA or the 227, in that the tumor is PD-L1 negative. There is an STK11 mutation present with KRAS, and the patient does have a brain metastasis. And David Carbone presented some data as well, suggesting perhaps reasonable efficacy for CTLA-4 PD-1 for patients with brain metastasis. So I think these are all things that would sway me a little bit towards at least discussing combination CTLA-4 PD-1. And when at Hopkins, at least, when we tend to use that regimen, we tend to do it as part of the 9LA, where you get the 2 cycles of chemo concurrently with the first 2 cycles. Yeah, it's almost like writing a case where you might think of that regimen, I think. Although, having said that, chemotherapy with pembrolizumab is also approved in this setting, and a lot of this is almost putting together tangential evidence to try and choose between the two, you know.
Mm. And at Hopkins, is there like an emphasis on pathways, or is the decision to, on how one chooses that upfront, is it truly kind of an individual decision for that particular oncologist, or is there, kind of say a bent or a
Yeah, if it's on the compendium and essentially everything that's NCCN 2A and above, so is on the compendium, then we're permitted to choose that. So there isn't a pathway necessarily. We do have something close to pathways for earlier stage lung cancer, so stage 1 to 3, but not so much for the treatment of metastatic disease.
Well, thank you, Patrick. Actually, I may turn it to Jared as well. Actually, Jared, at UNC, how do you guys process, similar types of scenarios? And in your specific, opinion on this case, actually, how would you proceed?
My thoughts are relatively similar. I mean, you've packed a lot into one case here. You've packed in a lot for conversation. And I actually think that you're wise to bring up pathways in the context of a complex case like this. I believe in pathways as potential to improve standard of care, help us to do the right thing, increase trial accrual. But if there were ever a case to argue that pathways are just not helpful, you've written that case, right? This is really an art of medicine case. And it's a very much it depends case. So, we're assuming, I think, that this patient's values are towards aggressive treatment, but 74, you want to know her performance status at my institution. She would get an abbreviated geriatric assessment. We don't take it to the nth degree, right? If she's clearly 74 going on 50 or 74 going on 90, you could be done. But she's a typical septuagenarian. We do geriatric assessment to better understand. Similarly, the brain met, how bad is it? Is there a lot of edema around it? Is she very symptomatic from it? When you get over a centimeter, particularly if they're symptomatic, if there's edema, the absence of actionability of a targeted mutation where the drug has brain penetration, I'm going to be leaning heavily towards stereotactic radiosurgery and not systemic therapy. Probably for that brain lesion. And then, gosh, G12V with STK11. G12V, as mentioned, is not actionable. There are ideas about how to drug it. I find silencing RNA a particularly exciting idea. STK11, of course, a controversial marker as being a negative predictor of PD-1 response. I don't think that's totally proven yet. I will put out there, I'm a believer that that's probably going to eventually be proven true, that the data is growing not only for decreased probability of response to monotherapy, but in the addition of PD-1 to chemo. So my thinking is similar. If the patient has no contraindication and is very fit and is interested, I would be thinking about Ipi/Nivo for this patient also. I think both of us would be in the minority probably in jumping to that answer, but if we are together. I'm not the biggest fan of the addition of the 2 cycles of chemo. I'm relatively unimpressed by how much 2 cycles of chemo add to the left side of the curve where it's supposed to help. Has-Borgai once told me that once you've reached associate, you're allowed to do cross-trial comparisons. So the 3 of us are, I think, allowed to do that together. And when I compare 9LA to 227, I'm not impressed by much of an improvement on the left side of that curve. And so it leaves me asking, if I'm going to accept Ipi's toxicity, and granted, Ipi's toxicity is very different at such a low dose and wide schedule, do I really need the chemo in there, especially for a septuagenarian? With brain mets and liver lesions, if you want, I guess you're leading to a higher risk cancer case, but really it comes down to how scared are you of the cancer versus of toxicities. And I've only once pulled out the additional 2 cycles of chemotherapy. For the most part, if I'm pulling out Ipi/Nivo, I've only once pulled out the chemo with it.
That's super interesting. I may ask a provocative question, actually, in this case, is that if one does use a regimen like 9LA, have either of you ever had a practice of going beyond the 2 cycles of platinum that were indicated as part of 9LA? Is, if a patient is responding and perhaps having a deep response, is there ever consideration to kind of continue additional chemo beyond the 2 cycles?
Gosh, I can't wait to hear what both of you have to say about this, because the only case I've ever done it, I'm tempted to do that in. Very young patient with a non-neuroendocrine, an endocrine large cell, endocrine type large cell carcinoma, that I gave the 9LA to. That's my only patient. Has had an absolutely brilliant response to 2 cycles. So I'm curious what you both say. I've never done it before, but I'm tempted, and I'm curious what you both think. I'm going to learn from both of you.
I haven't continued it on, Hatim, but I have reintroduced it. I've had a couple of patients who've had a response, and then a year later they've started to progress, and I've added back in with some more chemo at that point. But that's the main setting. The other situation which you sometimes come across, because Ipi/Nivo is approved for PD-L1 positive, but in the NCCN guidelines for PD-L1 negative 2A recommendation, sometimes you're pushed towards using the 9LA for the PD-L1 negative patients if the insurance will not approve Ipi/Nivo on its own, you know. But I think either are reasonable options, you know.
Yeah.
I think reintroduction would be my preference rather than keeping going for more than 2 cycles.
Yeah, no, and I agree with you, Patrick. Actually, that's been my experience as well. I think patients are quite excited about some of the considerations around the 2 cycles. But I do wonder, especially in patients actually who have had deep responses. I remember actually when I was a fellow at Hopkins, I remember kind of with Dave Ettinger having a small cell lung cancer patient who we decided to go to 8 cycles of platinum, partly because they were still having a deep response. I mean, they're still having a response after, or kind of with the 6 cycles. So, there is some practice pattern variance here. And I think, that's why I think this is a great discussion to have, is to just really understand how, the fact that some of these real life scenarios, but really understanding, should we be continuing chemo in people who have plateaus, meaning in terms of the depth of response, or those who are having ongoing? I think another area that I wanted to kind of talk through, with you both about this as well, is how, obviously this patient had PD-L1 testing. The PD-L1 was negative, 0. How are you guys integrating TMB? Is TMB something that is coming up on panels that you're using? Are you integrating it into the front line for decision making for patients? And maybe actually I'll turn it to Dr. Weiss first, and then Dr. Forde.
So I get it. I don't have a choice about getting it. When you send off DNA NextGen, you get tumor mutational burden. I am not integrating it into my practice, other than maybe very borderline cases to help, and by borderline, I mean once or twice a year. I'm not routinely integrating it into my decision-making at this time, although as data evolve, I would certainly love to be proven wrong and to change practice and have a more useful biomarker, because as your case really reflects, PD-L1 is a lousy biomarker. There are patients with a PD-L1 of 100 who do not have a response to monotherapy checkpoint inhibition, and there are patients with a PD-L1 of 0 can have brilliant response. And we have trial data certainly that the addition of drug to chemo is beneficial even in that population. That's not a good biomarker, but I'm not sure that TMB really gets us there.
I would agree. And I think where it may be useful perhaps is at the extremes. So say you have TMBs of 25, 30, 40, those sort of levels, and it might give you some reassurance, for example, in this for this patient, if you had a really high TMB, that perhaps IO is going to have some benefit. But other than that, I don't find it too useful. I had a very similar patient, actually almost identical, except he didn't have a brain metastasis recently, and I did the checkmate 9LA, and his TMB was 2 as well. So he had all those characteristics that you kind of think is not going to respond. And within literally 3 weeks of starting, he was feeling much better. Now, whether that was the chemo or whether it was the 9LA is hard to know, but he was much, much better than he had been when I saw him in clinic. So that's gratifying, at least.
Yeah. No, and I will tell you about two patients that I've had now about 4 years ago, who really framed how I think about TMB as well. So I had two patients around the same time who came in with AIDS, HIV, and one of them had high PD-L1 greater than 50%. And at the time, pembrolizumab was approved in that, and that was an on-label consideration. Another patient actually, the other patient had a PD-L1 of about 15%, but a TMB that was about 25 mutations per megabase, which would be about 95th percentile, in lung adenocarcinoma. So because of some of the considerations around the HIV, the patient really did not want to receive chemo, and there was Keynote 42, that we acted upon in that way. Both patients actually 4 years later are still doing very well on the monotherapy. One patient, did have progression, kind of with things, and we've escalated his therapy. But I think as a whole, both of them chose monotherapy and have been doing well. So I think speaking to Dr. Forde's point, really understanding the extremes of TMB and how those extremes can be integrated in some of the thinkings, at least as an area of further exploration consideration. And I think that in real life, with us getting this information, acting upon it. I may ask actually, in both of your practices, is the molecular profiling being done in-house, or is that something that's a send out where you would get commercial assay for the TMB?
At our institution, it's done in-house. So there's an NGS panel done, which gives you TMB and mutations and amplifications. And then there's an RNA-seq panel as well. But it takes about 3 to 4 weeks. So not infrequently, we still send off a liquid biopsy as well.
We send ours out, although we also have time factors that are a problem that lead us to liquid testing.
And may I ask actually, Dr. Forde, when you say kind of the RNA strategy, is that something particularly oriented for fusions, or is it kind of like a RNA-seq across the genome?
It's so it's a nanostring type. So I think it's 250 fusions in the common fusion seen in lung cancer. There's a lung cancer version, and there's a sarcoma version, and a few others as well that they use. So they apply. It doesn't detect all fusions, just the well-described ones. So they actually still do FISH as well. So it's multiplexed, unfortunately, in multiple different ways.
This is, I think, a very important point for community practice, that guidelines sometimes let us down on a little bit by speaking too vaguely. Guidelines will say, well, you should test broadly and with a sensitive method. The good testing, the optimal testing, is DNA next-gen with an RNA fusion panel if you're sending something out commercially. Otherwise, you actually really do miss stuff. I've had patients that had a la carte testing, so some PCR, some FISH, where I've sent off the next-gen looking for, okay, looking for things that weren't tested for, and I've gotten back EGFR and ALK. And then as well, if you don't have that RNA fusion panel, you can miss a lot of MET-del14. You miss the larger fusions like NTRK. And I've even had RET granted with novel partners, but that were not picked up on DNA next-gen, that were on RNA. So it's not just an academic thing. You really do pick up more things if you do that, and it makes a tremendous difference in the life of those patients. And then for the purpose of our conversation today, of course, many of our molecular predictors, in addition to being strong predictors of targeted therapy efficacy, are rather powerful negative predictors of immunotherapy efficacy. And some of our TKIs are more toxic when given after immunotherapy. So it's sort of a triple threat of reasons why it's really critical to not only know that molecular, but to know it before considering giving immunotherapy. And in my practice, if I have a patient who really needs therapy, then that therapy is going to be PEM-carbo or PEM-carbo-bev if you really want to tack something onto it, but not triplet therapy and not IO monotherapy, no matter no matter how high that PD-L1.
And speaking in that vein, and totally iterate and think really important kind of your comment, Jared, on the having the molecular information early and upfront. I think in real practice, though, sometimes, especially kind of in using liquid biopsy, we may get a liquid biopsy result. And, an oncologist is in a position where we have some information with the liquid biopsy result. And let's just say it's come back negative. Now the question—
Well, we must clarify what is a negative. Is a negative that you don't know the answer? Is a negative you have an answer that makes you sad because it's not actionable? In the latter case, you can be done. In the former case, it's undefined.
But let me ask you about that former case, right? Where, and completely agree, and I think kind of there even are efforts for the liquid biopsy to really define this concept of a true negative versus an undetermined, value that is not reported, at least, is kind of perhaps one way to phrase that. But let me just ask you about that exact scenario. I have this patient, we've sent off the liquid biopsy. It's come back not reporting an actionable gene. It's 2 weeks, since the first time that you've seen them, because you've done the test then. Now we have to send off the tissue, and it may take another 3 to 4 weeks if it's a send out test. Would you be tempted, or would you approach integration and starting the patient on, say, chemo IO first, or would you then still proceed with just chemo alone to go forward?
Well, so first, y'all must be much more patient in California than at least in the Southeast. If I'm sending off liquid, I'm not waiting to send off the tissue. It's sent off in parallel to exactly avoid that situation. And there are all kinds of reasons why that could be wrong and can be not cost effective and can be easily criticized. But for exactly this scenario is why I'm sending them off together. But my simple answer is no. If I give me 100 pack-year smoking history, I'm intentionally exaggerating, non-squamous disease, and no answer from the liquid, I will not add immunotherapy on cycle 1. Dr. Forde, do you feel differently?
No, I tend to agree, actually. So I can think of one patient maybe where I've proceeded, and that was a very unusual. I was actually trying to get tissue out of California, which was not easy, but no. So what I tend to do is very similar to what Jared was saying in terms of we would send the liquid biopsy, and then if you have a sample, send that at the same time, or else arrange the biopsy. And that worked out recently. For example, I saw a patient, a never smoker, who had leptomeningeal disease, and it had 2 biopsies at an outside hospital, both of which did not deliver enough tissue. So I sent a garden to arrange the biopsy, which was going to take about 7 to 10 days. And then by the time the liquid biopsy came back, which didn't show anything, she had the biopsy the following day. So I think being proactive makes sense. And in the end of the day, she actually had an EGFR exon 19 deletion. So I think those sort of proactive approaches, that was a situation where I didn't really have another choice because chemotherapy was not going to control her leptomeningeal disease, But in general, I think that sort of approach is preferable if at all possible.
Yeah, no, I think it makes sense. And I think, definitely, iterate that. We do try to do that under certain circumstances. The insurances, especially if there is a vendor, commercial entity that does both the tissue and the plasma, there is like a quote unquote red flag that's kind of set up in that way. But it appears not to be as big of an issue if different vendors are used.
So some of the vendors have been smart about that. At least one vendor I know, because we use them, if you send liquid and tissue, guarantee that the patient won't be billed for both, right? That they'll only bill for one. And so that most of us in the real world are sending out, right? I wish we had it in-house. I'm jealous, but most of the world is doing send out, and that's a strategy that can be employed. Use a vendor that does that.
Yeah, and actually, Jared, I really like that you commented on this, partly because the field is kind of incumbent on creating a sustainable system that isn't built upon circumstantial, scenarios or situations. And I think that, it may fall into the realm of how, these things get processed downstream of downstream of the oncologist to really, facilitate. So really like how you commented on that. Well, no, I think it's really important. And I think that the molecular is key, especially in light of what you commented around a negative predictor tool. I actually did have some slides here, really showing the differential responsiveness for certain genes versus others. We can see that KRAS, may have a higher response rate than other genes. And even if we look in the case of ALK, that had a 0% response rate with IO. Granted, these were second line and beyond patients. But some of the patients who have certain genes, such as say BRAF mutations, as well as MET, may have slightly higher responses than EGFR or ALK patients. Mm-hmm. So along those lines, actually wanted to kind of just broach one other concept as it pertains to this case. And this has to do with the diversity of frontline available agents. And we spoke about Checkmate 9LA. We spoke about Keynote 189. And wanted to kind of, get your thoughts about the Empower 150 regimen, and kind of if in your experience, kind of how is that being utilized? Is it being utilized in the front line? Are there circumstances where you may think that regimen through vis-a-vis the other regimens that we've spoken about?
I've mainly used it in the setting of EGFR, either classical EGFR mutations or exon 20, after exhausting prior TKIs for exon 19 and 21, or upfront for exon 20. I think that's really been the only scenario where I've used it. I know some of my colleagues use it a little bit more broadly, but not to a huge degree.
I have nothing to add. My practice is identical.
Mm-hmm. I may ask, actually, just speaking about that a little bit more in detail, though, is, if you both kind of feel that there could be a value for the VEGF inhibition, and especially in light of, data presented about VEGF, do you feel like there's a place for the VEGF synergy with IO, and how does that play out in your practice at all? Is that ever consideration as you approach? It sounds like it's not a consideration as much in the first line. Is it a consideration in the second line? And kind of how are you thinking that through?
So you're baiting us on the ASCO data.
Well, or just trying to understand, because I can tell you this is that, my use of single agent docetaxel has really declined, kind of since IO as a whole, has been adopted in the front line. And, I've thought about that a lot, because I remember prior to IO, being integrated in the front line, and where I did my training, actually same place that Patrick did his training, we used a lot of docetaxel monotherapy. And I remember having discussions about, whether or not there'd be value for docetaxel ramucirumab. But, kind of after IO, I've used it more. Now the consideration is there an additional value, or is it just kind of stemming from the original data about docetaxel ram that, posited some synergy between the taxane and the VEGF. So I just wanted to kind of get your take. It doesn't have to relate exactly to the ASCO, but I think the ASCO does provide some type of, additional info there.
Patrick, I know you have some strong feelings on this
one. I'm a little bit skeptical about the lung map trial, to be honest, but it's mainly related to the populations enrolled, in that we've seen some post PD-1 trials reported where there's quite a big differential between patients with primary resistance to PD-1 and those with acquired resistance. And no matter how much you control, I think the Pembro RAM versus standard of care trial was you had to be more than 84 days on your prior PD-1 therapy, but that could have been in combination with chemotherapy. It could have been sequential. So depending on how those patients played out between the two arms, you could potentially see differences which are more prognostic rather than related to the treatment that they're receiving. So in my opinion, it wasn't practice changing for me. I would not necessarily use Pembro RAM for a patient in the near future. But if there was a phase 3 trial with similar results, then I'd be tempted, you know.
I fundamentally agree. I think the purpose of a phase 2 trial, whether randomized or not, is to tell us whether we should do a phase 3 study. And when they're blow away enough, then sometimes we stretch things a little. Well, we stretch things from phase 1 expansions now, right? When we do get blow away enough, we've had multiple agents approved recently for that. This was certainly not. This was not enough for me to be tempted to change practice based on phase 2 data, even randomized phase 2. I think it was good enough to cleanly justify a phase 3 trial, and I also look forward to seeing what it says.
No, well, thank you so much for your insights there. I may also just ask, practically for docetaxel RAM, are you both using that, or are you still, or is docetaxel monotherapy kind of an agent that you guys are using more commonly than docetaxel RAM in the second line?
You know, all three of us are at academic places, right? So if you have a truly fit patient at UCSD or Hopkins or UNC, why is that patient not on a trial? And if the patient is not fit, then you're probably not that excited to write dosi or dosi-remu. To my mind, this is more a regimen for the patient who doesn't want a trial or doesn't want to travel to an academic center. And there I am using dosi-remu, but not with tremendous enthusiasm. It's sort of recommend with yawn for what it's worth. But I don't know, dosi, beyond the toxicity tables of trials, drugs have this axis of doc, I feel great to doc, I feel awful. Fatigue is a dominant contributor, but not the only one. And I think dosi is just a bad drug on that axis. The patients don't feel well on it. And that's kind of our whole raison d'etre.
Yeah,
I would agree completely. Theoretically, I would use it, but it's actually a relatively small number of patients who fit the criteria Jared outlined, who are not trial candidates or don't want to do a trial and are fit enough and don't have contraindications to VEGF, clear contraindications to VEGF,
But if you force a standard of care answer, like go Neil Love style, take all the trials away, dosi-remu is the standard answer. I think there's nothing wrong for patients whose values are oriented towards something a little bit gentler and willing to be out of the box. I think there's nothing wrong with writing an alternative taxane or gem or even VIN for these people. None of these, dosi-remu is not a home run, right? It's barely a bunt-on single. And so I think if, for the patient whose values are so oriented, I think there's nothing wrong with off-label using a different cytotoxic here.
Super helpful, comments here. Thank you for sharing that. So there are a few other topics I kind of wanted to broach. In the beginning, you had commented that the performance status of the patient is fundamentally important, to kind of really guide on the first line therapy options and strategy. Wanted to kind of probe your thinking about patients who are PD-L1 1 to 49, who either because of performance status or because of personal preference may not want to get chemotherapy. How do you approach those patients and some of the conversations with those patients? Do you offer Keynote 42, Checkmate 227? Kind of how do you think through, 1 to 49 category of patients who really, kind of may not be as interested in chemotherapy?
Patrick, you want that or should I?
Go ahead, Jared.
So I think so Pembro is FDA approved for the 1 to 49 population. I think that's a consequence of what I like to call Russian nested doll analyses. as opposed to discrete subgroup analyses. I don't think that's the right thing to do for a generic patient. I think if you have a patient who hates chemo, maybe, I don't know, a relative got chemo for a different cancer that was more horrible and they're just never going to take chemo, but they're super fit, that's where 227 and 9LA come in. The one place where I would actually consider pembro monotherapy seriously is if my fear factor is low. So you give me a patient without any central disease, not bulky, not symptomatic, not rapidly growing, right? We've all had these patients where you know they have metastatic disease, it's biopsy proven, but there's very, very little there, maybe a few dots in the lung, one of them has been wedged and proven, and where a progression event is going to be a radiographic event and not an event that ends life or affects quality of life, sure, I'd consider pembro mono. But for the most part, I consider that an inappropriate therapy. And I think it's an artifact of the way we do approvals based on predefined statistical analyses, something that I would want to do for my patients.
Yeah, the only thing I would add to Jared is that it's like not a binary variable either, in that a patient with a PD-L1 of 45% is probably different to a patient of 5% or 0%, you know. So I think taking the whole context in, and there's data to suggest that. I think the Mark Awad and Matt Hellman and those published a few studies on looking at the deciles of PD-L1 expression. So I'd be more comfortable in that scenario with something closer to 50 rather than something very close to 0, where I might think of the 227, the Ipi-Nivo approach that Jared mentioned. It hasn't for some reason come up very often. I can think of 1 or 2 patients who've been very chemophobic, but it probably varies by your patient population as well, you know.
Yeah. And I think age also, you know, I think that, you know, especially I've had some patients actually who, you know, particularly those actually who are above 80, you know, who you really kind of have, in some cases, aversion to chemotherapy. So really, you know, really great. And again, you know, this is for practical tips, you know, for oncologists as a whole. So I think it's really helpful to hear some of those views.
By the way, some of this comes back to an old data, right? That's, I think, older than any of the 3 of us, some of it. But, you know, the Elvish trial showed us that not only for duration of life, but also quality of life, single agent vinorelbine was better than placebo. And we now have 2 trials that look at the PS2 elderly as a subgroup. One was a PS2 trial with an elderly subgroup. One was an elderly trial with this PS2 subgroup that show better survival with doublet chemo than single agent. So there's a matter of patient education here about quality of life being driven not only by toxicity of chemo, but also by the side effects of the cancer. And I think there's also an education component that lung cancer chemo, particularly talking about PEM-carbo, is not as awful as leukemia chemo or breast cancer chemo, or in my opinion, even colorectal chemo. We have some, you know, PEM-carbo, I think, is one of the gentlest doublets in all of oncology. Not all chemo is similarly awful. Gosh, I didn't want to have to ever defend chemo, but they are differentially awful, and PEM-carbo is a gentler regimen as chemo goes.
In speaking to that point, and again, because this is for practical, you know, tips for all of us, you know, in different ways, is, you know, what are your thoughts about reducing the dose of chemo for patients, and how do you approach, you know, even starting the patients on chemo? Is it something where you feel comfortable starting with lower AUC carbo? And, you know, how do you think through that decision? Do you wait to see if patients have toxicity and then kind of dose reduce? Do you just empirically kind of dose reduce for those who, you know, may be frailer or kind of have some other, you know, how do you consider that first dose for the chemotherapy for patients?
I do tend to dose reduce docetaxel quite a bit for patients starting down to 60 or even a bit lower, or 60 per meter squared. For first line, I don't tend to really reduce too much, except I do watch the GFR pretty closely. So if the patient is down towards the 45 to 50 GFR, I might be tempted to drop the pemetrexed down and maybe even the carboplatin, or if they are particularly frail. But usually I see how it goes with the first cycle. Provided their GFR is normal and they're otherwise fit. I don't know, do you guys do anything different in that regard?
Yeah, I
I
mean,
have some, go ahead, I'm sorry.
no,
I-
actually, I'll let you kind of speak first. Then.
Yeah, I'm more binary, just like Patrick. If because again, coming back to the fear factor of the cancer, I view this a little bit like Superman jumping between buildings. Stay on the rooftop you're on, you're safe. Jump really hard and make it to the next rooftop, you're safe. Jump gently. I think that's where we hurt people the worst, where you can end up with both toxicities of therapy as well as absence of a response leading to cancer suffering. I don't dose reduce frontline very commonly at all. I agree docetaxel, there's some data out of China from years ago that 60 is probably as good as 75. Wasn't the world's highest quality data, but it said what I wanted to hear, so I embrace it. And I routinely start dosing at 60 also.
I think, all excellent points. I think in my practice, actually, there are some patients actually that I do, that have with chemotherapy had, some pronounced hematological toxicities, with obviously thrombocytopenia or leukopenia. In fact, actually, I just saw a patient today who, we started with, with chemo IO, and 1 week in, kind of platelets are 17,000. And, I think there are, scenarios where, one could think through, is there a patient who is a better candidate to have a lower dose, than others? And, it's curious actually, especially in light of the fact that the dosing for chemotherapy was built around a maximally tolerated dose when it was, considered as a single modality of therapy with cytotoxics. Now with IO, I think kind of really understanding, that dose to benefit ratio as it pertains to that, I think is truly an unmet need, I think, and, kind of where the field will move in that regard is, be an interesting thing to see how that plays out as well. That's an interesting point. No, so I think that's one area of discussion. I think another area of discussion that sometimes comes up is that we now have different dosing strategies for patients. We have Q3 weeks, Q6 weeks. Have either of you really adopted the Q6 week dosing for Pembro? Is that something that you routinely use, or are you still using the Q3 week dosing?
Yeah, I do. I have a number of patients on the Q6 week. I generally don't start with the Q6 week unless it's a patient is very keen to do that for some reason. So in general, I start with Q3 and then switch over after a period of time if they haven't had toxicity, partly because if they're going to have early toxicity, which is not very common, but it can happen, then you don't want it to be locked on for 6 weeks. And although it probably will be anyways. And then the other thing is the chemo concurrent schedule kind of limits it's generally in the maintenance, you get to use the Q6 week if the patient is not getting maintenance pemetrexed. But during the pandemic in particular, we either stopped pembrolizumab for quite a few patients, and some of them are still in remission, or we switched to Q6 dosing for patients who didn't want to come in very often,
I use a lot of it. UNC is the state hospital in the state of North Carolina. So a lot of my patients come to me not because they can for trials, but because they have to, because we accept patients with no insurance and any insurance or almost any insurance. And so if you have a poor person traveling 3.5 hours to see you, where it's a hardship for a relative to take the day off of work, it's a hardship to afford the tank of gas, the every 6-week schedule can be really quite a bit better. So I also really like to start people on every 3 week. But if things are going well, I have most of my maintenance patients on Q6. Even if people can afford to come in every 3 weeks, we want to demedicalize their life, right? If they're doing well, if they're not having side effects of the treatment, if they're not suffering from their cancer, we want them out playing with their grandkids, playing golf, working, whatever it is that's important to them. And if you want to monitor them more, then have a quick video visit in between at the 3-week mark to make sure they're okay, or have your nurse call them. But I really like having people out of the infusion room as much as possible.
I think really great considerations there. One other area that I wanted to kind of broach is, we've now probably had patients who have reached 2 years of immune therapy and still not have progressive disease. Wanted to kind of ask like how you have that conversation with patients about reaching that 2-year point. Do you ever hear from patients that they want to continue beyond the 2 years, and how do you kind of juggle some of that discussion?
I find our academic conversation around this odd. We seem to have an academic consensus that we should stop at 2 years. And I think we don't really know that that's true. I don't know how long somebody should be on immune therapy.
And Patrick, how does it go for you as well?
Yeah, I tend to agree with Jared. It's really not defined. Like we've had patients, as you probably know, Hatim, when you were here, and you probably have as well, but I have several patients, and Julie Bramer has patients who are 10 years out after a couple of doses of immunotherapy, and for various reasons have not received further therapy, and they're still doing fine. So it's kind of so that makes me a little bit, I'm probably one of the people here who is more keen to stop therapy at an earlier point. So I definitely will suggest it to patients coming up to 2 years that we stop at that point if they're responding. I think the other thing to keep in mind that there was a study published in the JCO, I think last year, where they looked at, was it stopping after 1 year, and it perhaps suggested you should continue. But the difficulty, I think, with that study was it enrolled both patients who had a objective response, but also those who had stable disease. And stable disease is quite heterogeneous when you talk about immunotherapy. So stable disease can be a patient who's going to be stable for forever, and it can also be a patient who's just been stable for that year, but in reality is slowly progressing. So I think if a patient has had a very deep response, I'm very comfortable stopping at 2 years, or even before that if they have any hint of toxicity, or if they want to stop sooner.
Circulating tumor DNA may one day help us here. And I know I'm speaking to someone with much more interest in that than myself, Dr. Husain, but in the head and neck world, where we have a standard of care circulating tumor DNA assay, and our HPV positive patients who are NAD on immunotherapy who've had a positive assay in the past, if we can get a couple of negative circulating tumor DNA HPV assays under our belt, many of us are using that to help adjudicate stopping. We don't know. We have no proof that's the right thing to do, but I think the basic idea of doing something, whatever ends up being the best technology to answer if there's still cancer inside of a person, may really help get us there, right? There are certain mutations that you should never find in the absence of cancer. And if that's present in your cancer and you can still detect it in the blood, then there's probably at least still something to treat. Whether it helps to keep treating, I don't know, but there's at least disease there. In the absence of it, maybe that can help push you for people that you can stop. I'm wildly speculating, but it's certainly something being done in the head and neck world now and again now.
Yeah, no, I think really important points, and obviously, as the technologies also evolve and our understanding about when to use the tests, I think that'll really kind of, be an important biomarker strategy. As was referenced before, both Patrick and Jared, that you guys commented on ctDNA being integrated with IO, and obviously at Hopkins, kind of with ELSA as well, kind of, tremendous work being done in that regard. So I just, we have a few more minutes, and actually just in the final moments, actually, of the discussion, I wanted to kind of probe your thinking about where the field is moving a bit. And I think that, some of the areas are around what you guys see as clinical trials that may shift the bar and move the field forward. There's been a lot of discussion on other checkpoints, including TIGIT and LAG3 and TILs as a whole, for cellular therapies. Like, where do you see this field moving? And specifically, if you break it down into the front line as well as second line and beyond, that would be, helpful. So maybe actually, Patrick, I hate to put you on the spot first, but maybe if you want to kind of just
the stuff he's into is much more likely to hit the shelf in the next 5 years than the stuff I'm into. So I think that's smart too.
Well, I think we were talking about this earlier, but some of the ADCs, the antibody drug conjugates, I think they're probably the closest to broad-based application if you don't talk about mutation-specific therapies. So I think TROP2 in particular, potentially HER2 ADCs and lung cancer. I think I'd be surprised if they're not standard of care within the next few years. Perhaps in the first line setting, I know for example, TROP2 is being looked at in phase 3 trials in the first line setting, replacing pemetrexed in kind of a platinum doublet type approach with immunotherapy. And then in terms of other therapies, I think we'll see more therapies for KRAS as well, emerging hopefully for other KRAS variants. And then obviously, not to hog the conversation, but I think we're also seeing things finally move into early stage disease. And I think the neoadjuvant setting gives a lot of a platform to study some of these therapies in early stage disease and maybe even start using them at an earlier time point. Those have been my thoughts.
No, and thank you, Dr. Forde. Actually, I may actually just follow up on one of your comments before we go to Dr. Weiss's. As it pertains to IO, do you see IO remaining a backbone of therapy or kind of continuing as a backbone of therapy beyond the front line? Like, do you see IO as something that's kind of specific in the front line, or do you kind of see it more as like an expansive, almost like foundational element through time for patients?
Yeah, well, I think the lung map study would suggest that perhaps, and I think other phase 3 trials in this setting are starting to look that way as well. But there have been ups and downs. The lenvatinib pembro trial, I think there was a press release saying it was negative in the pre-treated population. So it's not going to be. I think we'll have more failures than we will have successes, but I suspect that PD-1 for non-mutated, non-targetable mutated lung cancer is going to be a backbone for a lot of our therapies for the near future.
So that's super helpful to hear. Actually, Dr. Weiss, actually, your comments on this?
So, I sometimes think of PD-1 axis agents like gasoline for the fire, but if you pour gasoline on an unlit log, all you have is a wet, smelly log. And so I think, I look with interest to therapeutics that can potentially light that fire. Some of these are off the shelf, like some of the intrinsic immune activators, STING agonists and toll-like receptor agonists. But I also look with fascination to more patient-specific approaches. I've spent years working on the development of a personalized neoantigen vaccine. Other groups have put a lot of work into that same idea as well, with different informatics generating the choice of neoantigens. We'll see where any of that goes. Cellular therapeutics, I think, are of high interest. I think that the potential for FDA approval of TIL therapy for lung cancer is under-recognized and under-discussed. I think we're going to have our first approved TIL therapy for lung in the next year or two, depending on decisions at the FDA. And there are multiple companies behind Iovance that are improving the bioinformatics and the conditions of the bath that might rejuvenate some of the cells. And then I and others spend a lot of time in CAR T, and I think CAR T is important as a member of a class of therapeutics that can potentially action loss of HLA and other elements of the antigen presentation machinery. TRACER-X shows us that the greatest evolution of cancer is not in reference to anything we do, even including immunotherapy, but rather to avoid the immune system, and that most of what we're adding to PD-1 in next line doesn't address any of the mechanisms that they and others have shown us to be dominant. CAR T can, and NK-directed agents can, and I'm sure there are going to be other ideas about how to bypass that.
Well, thank you both. Actually, it's been such a enlightening discussion, and I'm sure all of these tips and tools are ones to really reflect upon for all of us. Partly because as we started, there in some cases is not necessarily say one right answer, for these patients in scenarios. So with that, actually just want to really thank you both. And actually, I'll turn it over to Dr. Laskari as well for some concluding remarks.
Thank you so much, everyone. I really appreciate, we all very much appreciate this wonderful discussion. We've learned a lot. Thank you so much, Dr. Hatim, Dr. Weiss, Dr. Forde. Yeah, this was a wonderful discussion, and I think we got a lot out of this one case. I think it really demonstrates how much we can learn from our patients. Yeah, even a few of them can be quite enlightening in terms of how we approach these cases. So thank you once again, and we look forward to our next discussion, which will be on July 27th, where we will be discussing adjuvant therapy in the lung cancer space. And that's another very exciting topic. Thank you once again, and good night, everyone.
Good night. Thanks.
Thank you.